think it's been great, Bruce. It's a fantastic forum. I enjoy it a lot. It's a time to catch up with general practice colleagues and see what sort of challenges they have in primary care of patients. And good chance for us to interact. I learn a lot at these conferences, and I'm always feel privileged to be asked to speak. Well, in our session today we had a panel talking about metastatic disease. A fantastic panel covering oncology, radiotherapy and surgery for metastases. And the big message I got today is that there's hope, even if you have stage 4 cancer. You can get some long-term cures and certainly excellent palliation with a lot of great new techniques and indeed new drugs. With regard to bowel cancer, firstly it's very common. Secondly, it's lethal, half the people will die. Thirdly, you can actually not only find early cancers but prevent them through colonoscopy. Now, how to do that is the challenge. I think we need to lower the barriers for any Kiwi over 50 to be screened. That would be ideal, any Kiwi over 50 to be screened. And the government has recently announced money in the budget towards rolling that out, slowly extending over all 17 DHBs. That's very positive. It's a start. It needs to have a lot more given to it, in my opinion. But I think if GPs take away the message that screening is very effective with this condition in particular. Yes, I think firstly the bowel cancer screening pilot at Waitemata has been hugely successful, and that's the most important thing, that people realise that it actually works. You save lives with the screening. The great problem with bowel cancer in New Zealand is most patients who present are stage 3 or 4, in other words they're advanced and not curable. Bowel cancer screening not only picks up early cancers, it picks up advanced adenomas, so you can prevent cancers. And the point is that colonoscopy is at the basis of this after fecal testing the population. I think there is a challenge in capacity for providing enough colonoscopy that this country clearly needs. I'm not heavily politically involved, but I can see that that will be very much a practical issue that needs to be addressed. Yes, at present colonoscopy is done pretty much by gastroenterologists and surgeons, and it's important that that training continues. We are having a lot of very good young people coming through the system. Matching up the person power with the need, I think that's going to be a challenge for the politicians. I don't have an easy answer to that. In some ways New Zealand survives on immigration. A lot of skills migrate here, and that may be a possibility, even bring in people on a contract basis, but that's just one idea, and I don't think this is clearly worked out. I think both public and private sectors are very busy. I only work in private, but from time to time we will do contract work for the public system, which can get quite overwhelmed. The need for colonoscopy is enormous, and they struggle just managing symptomatic patients, let alone screening and prevention. There will need to be money poked at this, but also, as you point out, capacity. We're all busy, but if the job needs to be done, it needs to get done. No, it's excellent. It's a lot better than it used to be. It's now an immunochemical test. The old GUIAC test was not particularly accurate, but the new test only picks up human hemoglobin, and you can dial up and down the sensitivity of it. You don't need a special diet, and it's just one test, so it's actually a very good test. It will improve. There's work about diagnosing bowel cancer through looking at DNA in the stool sample and possibly even a blood test, so there's a lot that's around the corner. Yes, well the gold standard is colonoscopy, and in an ideal world, if we could colonoscope every Kiwi from the age of 50 every 5 years, the simple fact of the matter is you would prevent most bowel cancer and certainly most bowel cancer deaths. That's not practical, that's never going to happen, so you have to look at what is practical, and to cut it short, fecal testing is really the technique of choice, and that's what most research is based on, and the Waitemata pilot. Very simply, patients are asked to send in by mail a very small stool sample, which they take with a little container, and they can post it in. If there's blood in that stool sample, then they get a colonoscopy. So colonoscopy is the best test, but the best test is the one that gets done, which will be fecal testing.